Good evening. Welcome to this Urowebinar organized by the European School of Urology. My name is Bogaert. I am a pediatric urologist here at the University Hospitals of Leuven in Belgium. The topic of today or this evening is vesicoureteral reflux 2017. To treat or not to treat, or maybe better, tailor-made treatment for your patient. I have no financial relationships, so I can have no problem in discussing this CME activity. First of all, also a special welcome from Leuven, who is famous for his city hall, for the béguinage, and of course for its beer. Special welcome also from our entire staff, of who probably you know a lot of them, who are active in other subspecialties. As I mentioned, we're going to talk about vesicoureteral reflux, and of course definition is part of that presentation. It's the retrograde flow of urine from the bladder into the upper urinary tract. This can be due to an incompetent uretrovesical junction. It can be permanent or transient, and it can be a primary disease, which is a congenital one, and it's called also the embryological butt theory. But it can also be secondary. Then it's not a disease, but a symptom. And that's due to lower urinary tract dysfunction. Tony Caldamone, also a pediatric urologist, once said, and these sentences are such words of wisdom that we keep on continuing what he once said. He says, look at 30 years of history of reflux, we became so expert in the surgical correction. However, understanding this significant problem, the natural history, and the true clinical significance is actually going to be still a challenge also in 2017. Vesicoureteral reflux has a prevalence of between 0.4 and 1.8 in childhood. It has a grading system between 1 and 5, and if something says it tends to disappear. First question you may have is, vesicoureteral reflux harmful? Well, probably not vesicoureteral reflux itself, that it was once said a theory about the Big Bang theory, but it's probably a mixture of vesicoureteral reflux and a urinary tract infection. However, meanwhile, we know that there are 4 factors that play a pathophysiology role. It's bacteriuria, it's the bacterial reservoirs, the renal parenchyma, and the bladder behavior. What about vesicoureteral reflux and renal anomalies? We find between 30 and 60% in the event of vesicoureteral reflux, also renal problems, renal anomalies. This can be congenital or secondary. Boys have rather congenital problems such as renal dysplasia, but there is actually no way to distinguish this by any imaging or exam if this is a congenital problem, a scar, or a reflux nephropathy. Vesicoureteral reflux and bladder dysfunction is quite an important issue and an important association. We know this, that there is congenital and secondary vesicoureteral reflux, but this is like the chicken and the egg, which came first. There is also, as you know, infants and children who are potty trained. Specifically in infants, there is a very high voiding pressure and dysenergic voiding in the event of vesicoureteral reflux. Later, when the children are potty trained, there is rather a dysfunctional voiding. And then there is a 60% correlation with urinary tract infection, and dysfunctional voiding with VUR is in 20% associated. The infant reflux is rather a high grade, and the potty-trained vesicoureteral reflux is rather a low grade. How about diagnosis? When should we think about vesicoureteral reflux, and how should we make diagnosis? How important is it to make the diagnosis? First of all, when should we think about vesicoureteral reflux? Well, there are four different entities. And first of all, there is the prenatal dilatation. And in the event of prenatal dilatation, in 15%, there is also vesicoureteral reflux. And this we know about this very large and very, very long-standing prenatal studies performed at Great Ormond Street by Dr. Dillon and Dr. Rensley. However, a normal prenatal ultrasound does not exclude necessarily vesicoureteral reflux. The second event where you should think about vesicoureteral reflux is a febrile UTI. It is actually found in about 40% of cases that we find vesicoureteral reflux after a febrile UTI. And that is actually mainly the first very good from large studies from the International Reflux Study, which is quite old, from 1992, but it's still valid. The third is bladder dysfunction in potty-trained children. Those children have recurrent febrile or non-febrile UTIs. It is also in the event of neurogenic or neuropathic bladder dysfunction. There is a correlation with persistence, and actually if bladder dysfunction is present also, you have to be very careful also after you've performed or you corrected the vesicoureteral reflux. And actually the fourth entity is in the event of siblings. So if you discover this in one child, you actually should also screen the other children, and it's between 34% and even sometimes in 50%, you might also discover a vesicoureteral reflux or other problems. Again, this is one of the theories of the bud theory, the embryological theory, as I mentioned initially. How to investigate vesicoureteral reflux? Is there reflux, and how much? Okay, qualitatively and quantitatively. Is there any renal damage, and are there any associated problems? Well, first of all, the vesicoureteral reflux, how do we examine this? I think it's obvious. We need a voiding cystourethrogram. You need a catheter because you have to do this in a direct way. You have to directly fill the bladder with some kind of a contrast medium. However, please be aware and be critical when you ask for a voiding cystourethrogram, because this is the reaction if you're going to tell one of your patients that you're going to perform this study. The specificity from a voiding cystourethrogram is quite high. However, the sensitivity is quite low. You can do this with conventional contrast. It gives you excellent information about anatomy of the upper and lower urinary tract. However, it can be 20% false negative, that you don't discover, you don't see actually vesicoureteral reflux. One possibility to overcome this low sensitivity is that you do in infants up to 18 months of age a tricyclic, I mean you cycle 3 times, you perform 3 times after each other avoiding cystourethrogram to actually to increase that sensitivity to be able to assure that you have found and made a correct diagnosis. The second method is the change of contrast medium. You can use nuclear cystography. It has a higher sensitivity due to the fact that actually you don't have to deal with radiation because you are performing continuous imaging. It gives you, in addition, lower dose of radiation, but actually the imaging and anatomy is less good than in the conventional contrast. And the third option is sonography. Actually, it requires quite high expertise of the radiologist, and it is actually quite intensive, time-consuming for the radiologist. A very good critical remark could be that you say, well, is there always VCUG necessary? You know, this is the so-called bottom-up or top-down approach. Do we have to perform this in all children with a febrile UTI? Well, actually, this study from the Swedish prospective trial, they looked at specifically those children with a febrile UTI and looked at two specific items, the CRP, C-reactive protein in the blood, and the AP diameter in ultrasound. Their hypothesis was, they said, okay, if the AP diameter would be larger than 10 millimeters, larger than 1 centimeter, or the C-reactive protein more than 70, could we then rather first perform a DMSA and then avoiding cystourethrogram to eventually, if this would be lower, that children would require no further imaging. Of course, in this study, they always performed all the exams, and then they tried to eliminate and to further filter this down. Actually, they concluded that if that cutoff value would have been implied in 126 from the 270 children, the DMSA exam could have been avoided. However, 9 out of 270 children with renal damage would not have been detected at all. So the bottom-up approach is every child with a febrile UTI should undergo avoiding cystourethrogram, an ultrasound, and a DMSA. The top-down approach is every child with a UTI should rather first have an ultrasound and a C-reactive protein, and then sequentially, eventually, a DMSA and or avoiding cystourethrogram. However, the top-down method is very far less sensitive. So this is another study. They've looked at another patient population, and actually it has shown that actually it's not reliable enough to screen for VUR. Another study has even looked at the guidelines from NICE and AAP, and also they actually were able to see that actually, look at this, so many children actually would have missed renal scarring and also in the AAP guidelines. So unfortunately, we still have to go for a bottom-up approach. What else do we need than the imaging of, let's say, the reflux and depict it? Well, it's clear we can do, and we have to perform an ultrasound. We should have done this in the first place. The shape is important, dilatation, and anatomy. And then renal function is important. Is there renal damage, or is there renal dysplasia? It's very important to filter that out. So the gold standard is here DMSA, which you could actually combine with or without chrome EDTA, because that will give you information about glomerular filtration rate. DMSA is a 100% sensitivity for renal damage and 80% specificity. You should perform this 6 months after UTI because a lot of the initial lesions, if you would perform a DMSA right after the febrile UTI, you see more damage than actually that will remain, because luckily most of the renal damage initially will improve or even disappear. And of course, as I mentioned, I will repeat it a couple of times, bowel and bladder dysfunction is quite important. So you need avoiding end-bowel diarrhea in the potty-trained children and eventually a video urodynamic investigation. That will be very helpful at all. And then there is something special. The DMSA shows scarring and the VCUG shows no VUR. Nevertheless, the child has recurrent UTIs. Then there is one specific diagnostic tool that we discovered recently, and that's what is called the PIC cystography. PIC stands for positioning and installation of the contrast. Now, it is very important if you perform a PIC cystography that you should do it in a very standardized way. Very important. You should take a very small cystoscope, a cystoscope of 9.5 French, and the contrast medium should be only hang on 1 meter above the bladder of the child, not at 2 meters, because you will blow the orifice open when you're in front of it, and not with a large cystoscope. No, 9.5, 1 meter. And then you can start looking, you put your cystoscope in front of the orifice. If that orifice opens up, you can actually classify this in hydrodistension. And the second step is, if you see this open, okay, you can put your needle, and of course you can start a treatment by intraureteral or subureteral injection with a bulking agent. This is how it looks like. That was exactly the patient that I showed you with the DMSA on the right side. The upper pole was damaged, and look, she has really, let's say, occult reflux, and she was treated efficiently with a bulking agent. So I started to talk about the treatment now. Let's talk about the treatment. There was a time, and we go back in history, where there was one treatment for one pathology. And to explain that, I told you a little bit, we're going to talk about fashion from the years 60, 70, 90, and 2010. And I'm going to tell you, in the 60s, it was thought that reflux should be cured all by surgery. In the 70s, it was thought it was like 180 degrees. No. Only antibiotics and wait long enough. And then in the 90s, suddenly the fashion was to inject all the orifice. And in 2010, people started to think again, maybe we shouldn't give nothing at all, not even antibiotics. So that's why we are here in 2017. We have the power of choice. So we ask ourselves two questions. What is the chance to grow out of it? And what is the chance this child would be in danger? What is the chance that this child would have another febrile UTI with possible renal damage or renal scarring? Okay, so the goal of our treatment is indeed to prevent the UTIs and also prevent this bladder bowel dysfunction. I cannot repeat it often enough, because bladder and bowel dysfunction is one main topic and one key cornerstone. I put it here in an, let's say, overview. You have the advantages and disadvantages. Doing nothing, well, you have a chance of spontaneous resolution, but you have a risk of UTI. Antibiotic prophylaxis, you have the chance of spontaneous resolution, but you have the risk of damage and antibiotic resistance. What about endoscopic injection? Wonderful. Outpatient surgery care, the same day going home, but the long-term results are not 99%. The long-term results are somewhere between 70 and 90%. And finally, surgical technique, I mean, it gives you immediate and permanent success, less than 1% complication, no more VCUG is required, but of course, it goes with a higher morbidity. Let me go back. All the prognostic factors. What are the prognostic factors that will actually determine if a child will have a high chance to grow out of vesicoureteral reflux? But first of all, the grade. The lower the grade, the higher the chance. Then, if it's unilateral or bilateral. Gender. Boys will rather tend to grow out than girls. The age of presentation, the younger you are, the higher the chance you will grow out. The older you are, the less chance. And then the clinic. Children with UTIs, with recurrent UTIs, will have less chance to grow out. And the children with renal scarring are, of course, at higher danger as well. And last but not least, the potty-trained children with bowel and bladder dysfunction are also at higher risk. And then there is another one, the wish of the parents, the compliance of the parents. And I ask you also to understand that. So I said, can we calculate the spontaneous resolution rate? Yes, we can. Well, at least we can try. There are here, I summarize for you, 3 websites where you can actually, from a mathematical point of view, you can fill out all these prognostic factors, the grading, the gender, the age, and so on. And then you hit the button, calculate, and it will calculate. It does that for the 3. And this study, wonderful study from John Roth, he looked at the 3 different, and he checked all of them. He said, well, there is still a quite big difference between those 3 calculators, and which one is correct. Actually, it still needs you and me to be there to actually tailor and individually calculate and estimate the risk that spontaneous resolution will occur. Can we calculate the risk? Okay, here it is. Take your, go to the App Store, but after this webinar, of course, and go and you put in iReflux risk calculator. Again, it's a mathematic calculator that will actually propose you a 2-year prediction that this child will have a febrile UTI. There are also other predictive factors. Again, the value of a low pressure vesicoureteral reflux. So the volume at onset is also a very important factor. This is another recent one from last year, who also is a mathematical calculation from another patient population. I told you how important it is the patient and the parents' compliance. Wouldn't you say, isn't antibiotic prophylaxis easy and safe? Well, I think the mothers and the fathers of you will understand that, look, it takes here 3 people to make this child swallow a tablet. So please think again, when you think about giving and prescribing, let's say for 1 year prophylaxis, this means there's going to be a scene every single day. Okay. Another picture I like very much, because during the reflux study where everybody says you only have to give antibiotics, this was like 5 years antibiotics. Look, this is 1 pill down, 1,824 to go. Antibiotics, you know it very well. It creates resistance, and it's actually up even in some areas of the world have endemic 30% resistance of sulfametoxazole and trimethoprim. And actually it increased the risk of resistance and also in the whole community. In addition to that, this was very, very interesting as well. This study has looked at how many patients actually fulfill their prescription. You prescribe the prescription and how many go to the pharmacist. Only 40% will do this after 6 or 12 months. And only in 17% actually they were measured in the urine. So actually the patient and parent compliance for 1 year antibiotic, it's not very much valid in all situations. Another recent study in pediatrics was that actually chronic antibiotics in infants actually could cause and could be one of the causes of obesity later. And also there, I think, even if it can put into a doubt a little bit, there is probably a truth behind it. Finally, I would like to finish with the guidelines. The AUA guidelines that date about from 2010. Look at this table. The first distinguish is below 1 year and above 1 year. And then the second distinguish is the bladder and bowel dysfunction. Of course, this is the American guidelines. You see here they are quite keen to offer circumcision quite early. I haven't mentioned circumcision, but indeed circumcision below 1 year of age can actually tenfold decrease the chance and the risk of a febrile UTI. Now the EAU guidelines, European guidelines, they date from 2012, and actually what they do is they put the children, they categorize the children in a low risk, in a moderate risk, and in a high risk. And I've tried to summarize this for you a little bit in an overview of this table to give you a sort of algorithm. So the first thing what you do is to distinguish the low grade up to the and compared to the high grade. So actually between 3 and 4. And the second distinguish is the, let's say, infants and the potty trained children. And the third actually factor that counts is renal damage. And then last but not least is lower urinary tract symptoms, bladder and bowel dysfunction. So again, you can imagine now that actually if you have a lower grade in infants with normal kidneys, they probably won't need much of a treatment. However, if you have a high grade potty trained children with renal damage and with lower urinary tract, they will require indeed urotherapy. The children without, they will require surgery. And here, as you can see, they require antibiotics or surgery, or in the lower grades, you can consider also endoscopic treatment. So this is the pendulum. Okay, very nice overview article. I also would like to recommend you if it to read it because, you know, use rather the curative approach in children with febrile UTIs, in young children, renal scarring, limited renal reserve, when antibiotics are ineffective, or if you consider that the compliance is not good, in girls, uncircumcised boys, and if the parents choose it. Okay, it's very, very important. Please help the parents to choose the right tailored treatment. And that actually was the message of my presentation, that please consider the low risk and the high risk children differentiate and consider all these treatment options. Maybe children would like to have circumcision. Maybe some of them would want to wait and see. Some children could benefit from antiseptic or antibiotic prophylaxis. The bladder and bowel dysfunction can benefit from urotherapy. Some could benefit from endoscopic injection, and some from urethral reimplant. And this is actually concluding my talk for this evening. And I will now look and hope that you will send me a couple of questions. I'm going to open this question here. What is the age of the child that we could, after proceed for operation? A child of 5 years, if there is no deterioration in kidney function. I think if the child is 5 years of age and still has reflux, I think it's very important you should look at the bladder and bowel dysfunction. Make a good voiding diary, very good stool diary, and actually this will guide you. As I told you, look at the gender. Okay, girls will probably less have tendency when they're 5 years to grow out. Boys could rather go, but again, look at the renal damage. Okay, so we go back to the algorithm. So I think this can calculate you very well the chance that this child will grow out. Okay, my opinion about the PIC cystogram to diagnose occult VUR in children with febrile UTI and no signs. I think that's probably somebody who wasn't present at the time that I presented, but I think yes, a child with renal damage, with no reflux on VCUG. I told you also in the beginning, avoiding cystourethrogram gives you beautiful anatomy, but has a relative low sensitivity. It has only a sensitivity of 20%. It improves if you cyclic perform the cystogram. So this could be one of the options. You cycle 3 times, you fill, and 3 times. If you still don't find it, I think it's worth to take this child to the OR, perform a standardized PIC cystogram. I repeat, a very small cystoscope, 9.5 French, and please make sure the height of the contrast medium should only be 1 meter and not higher. And again, because otherwise, of course, you can blow up every orifice there is, but I can guarantee you I have tried many children, and also sometimes it doesn't go open. It doesn't go open, and it happens sometimes in the contralateral orifice. And of course, then you see it. So I really believe that PIC cystogram has a very limited indication, but you should have it in your diagnostic armamentarium. The question comes if I trust these calculators and in how much. I told you there are 3 calculators, for example, to calculate the chance that the child will grow out. Okay, so that's the first one. And actually, the one from, let's say, deflux is actually the one from the International Reflux Study Group. It has actually only 1 or 2 parameters. It's the grading, unilateral, sorry. It has the grading, unilateral or bilateral, and the age. But these are the 3 factors, and that's the only one. So this is the less best reliable because it doesn't take into account the other prognostic factors. The other two ones, they're only calculators. They're based on mathematic models and based on a lot of patients. I don't know exactly, but probably 300 to 400 patients, and the natural course. These were 300 to 400 patients that were followed and calculated the chance that they would have grow out or UTI. And I think from that, give you a little bit an idea, and it helps actually to explain the parents. And I think you will always take a risk. Nothing is 100%, but at least it will guide us a little bit, together with your clinical, let's say, to a clinical situation. Okay, this is a very nice question. Who's asking me, what is the standard procedure of a VCUG? Actually, there are two very nice publications from last year, so you should check it out. I haven't included them in the presentation, but the first one is actually very well also that says, okay, you should notify, you make a plain X-ray, you use a catheter, you have the parents present, we don't sedate the child, we explain, we inform them very well, they can watch a little movie, and actually because of the parents, when the parents are relaxed, it's very, very, because I told you it's a very stressful exam, but it's very important that this is performed with the parents present. You can use some midazolam, but again, sometimes the children fight against the, let's say, this sort of arousability that it creates, and they will fight against. So our experience to use actually no specific sedation. Once the catheter is placed, we start to fill at about 50 centimeters, so half a meter high, and because of slow filling. However, you can also put it on 1 meter, and it has actually shown in a study from last year that there is no difference in discovering vesicoureteral reflux or not. You fill, and again, it is very important that you know the clinical, how would I say, the circumstance, because if you say this child has renal damage, I think it's very important that you eventually fill 3 times before concluding that there is no reflux. Of course, if there is reflux from the first time, you don't have to do that. But that's a little bit the, let's say, standard procedure, and I would like to invite you to read the article that was published on a consensus on how and what should be reported for the VCUG. Let me look for, okay. Question about reflux in transplanted kidneys. I think it all depends, of course, by the transplant surgeon. I think most transplants use a non-refluxive approach because of limitation of, let's say, vesicoureteral junction obstructions and vascularization. So most of them, actually, they put it on top of the dome. Most cases, they don't have infections. However, in some cases, they do have infections, and then we tend to treat them by injection treatment from a bulking agent with, I think, quite good results. Okay, very nice, good question also about screening in siblings. Siblings, I think is very important. There was a time that all the siblings were screened with VCUG. Please do not do that any longer, okay? We know there is a high incidence, about 40%, that siblings will also have reflux, but it might be clinical irrelevant. So please do not screen them with the VCUG, but my personal opinion is please screen them with an ultrasound. If you have, let's say, a normal ultrasound, normal urine, don't go any further. However, if you have any dilatation or you have UTI, you might really consider performing a VCUG, because then you will have the clinically relevant one. So to summarize, the best way of screening siblings is with a renal ultrasound. This is a question about vesicoureteral reflux and urethral. I think that is the event of the urethral duplication, because your urethral is not associated with reflux, but will be associated with the other pole reflux. So in the event of a renal duplication, you might have a urethral of the upper pole with obstruction and a reflux in the lower pole. So of course, if you have a clinically relevant child with UTIs or with really obstruction, you really have to consider to reimplant, or in the absence of vesicoureteral reflux, you might combine the upper pole to the lower pole. However, if there is a large urethral, it might be worthwhile to reconstruct the bladder neck and actually remove the urethral. How long should we follow up? Oh, that's a very good one. In the, let's say, low-risk children. Actually, I would follow them yearly with an ultrasound and with a urine control. So also the low-risk children, I would really recommend you to keep an eye on those children. It doesn't harm to do a renal ultrasound. It doesn't do harm with some urine control. And it gives you a good feeling, and the parents will really appreciate it, that actually you keep an eye on those patients. Of course, there should be an end, and probably it's like when they start to become pubertal and everything is fine, I think you can stop, which is probably between 12 and 14 years of age. Somebody here is asking about a 13-year-old girl who underwent surgery at the age of 7 with an extravesical approach. He performed avoiding cystourethrogram, and there is still a high-grade reflux with scars and high bladder capacity, urinary retention. You know, it looks like that this child, and I'm happy you were asking this question, this child has had bladder and maybe bowel dysfunction. And that was actually thought to be, you know, not of clinically importance after they corrected the reflux. So they corrected the reflux. It doesn't matter in what technique, but probably due to the bladder dysfunction, this child was not very well followed up and actually developed a secondary reflux due to the bladder dysfunction. So I think I would recommend you please first treat the bladder dysfunction, eventually, like you already suggested, with intermittent catheterization, and only if the bladder is stable, either with urotherapy or with intermittent catheterization, you have to redo that surgery. And I would rather do it then from an intravesical approach, and due to the fact that she has underwent surgery before, you have to consider a psoas hitch, which probably, and I hope for you, will actually be the solution for the child. And actually, I think, thank you very much for all the questions, your interest, and we have now finally concluded our 20 minutes of discussion. It was a very lively questions. I thank you very much for your attention. I hope you liked it, and I hope to see you somewhere sometime soon. Thank you and good evening.